All right, well, good morning, everybody. I think this is a good talk to just start off the day with, kind of just go over some, some basic principles, of arthrodesis. There's a lot of things that we talk about specifically to procedures and pathology. This is going to kind of encompass just some overlying principles that kind of keep in the back of your head when you're thinking about those things. And I'm going to also kind of touch on just we go back to teaching and some learning principles that also kind of affected me during my residency, and this idea of readiness, exercise, and effect we'll finish off with. So financial disclosure: I am a shareholder in Osseo. I mentioned that for this lecture because there are some slides from them as far as their manufacture of a product called Osseo Fiber. I don't mention them directly in the lecture, but for completeness sake, I do have that disclosure. So when we're talking about principles of arthrodesis, we're talking about bone healing, and the differences between primary and secondary bone healing. So your goal with arthrodesis is to achieve primary bone healing when you're fusing two bones together, trying to get direct contact, absence of any type of bone callus. Although sometimes secondary healing can occur, it is important to understand that the main goal here is to have these two fusion sites oppose one another, allowing for osteoclasts and osteoblasts to get across them and create new remodeled bone. Indications for arthrodesis: obviously, joint pain, arthritis, instability at a joint, and of course, correcting deformity. And our goals are relieving pain, correcting any deformity or malalignment of the joint, and improving on a patient's instability or improving on any underlying deformity. So this is usually used when an osteotomy or soft tissue balancing just won't work, and it's not going to be enough to correct the patient's problem. This is kind of the facet that this whole talk was started with. Glissane's principles, and we'll kind of go through all of them. And these are the principles of arthrodesis. Complete removal of all cartilage, fibrous tissue, and any material that may prevent contact of raw bone surfaces. Accurate and close-fitting contact across the fusion site. Optimal position of that joint, followed by maintenance of that bone apposition in an undisturbed fashion until the fusion is complete. So these are, principles that were written in 1949 by Glissane, and they're still applicable today. So our strategy when it comes to arthrodesis, obviously, is when we're achieving whatever procedure we're trying to perform, our incision placement is going to be important. Anatomic dissection, joint exposure, resection, positioning, and fixation. We'll kind of go through every one of these in fashion. But our main goal, obviously, with our fixation and with arthrodesis is to promote bone healing across that joint. So landmarks are important, obviously, for exposure of the joint that you are resecting, as well as to allow for adequate placement of your fixation, and then also for closure and for optimizing healing. Obviously, when you are exposing, you want to look at what joint you are resecting, making sure you're adequately able to expose that joint, and then making sure you're going to have plenty of room in your dissection for the instrumentation that's going to be used for whatever fixation you're putting on. The AO principles of anatomic dissection are preservation of blood supply. And with the PI, we kind of go a little bit a step further. We're preserving also the nerves and the veins. There's also tissue plane dissection, dissecting down in layers and then closing in layers and using anatomic pathways to get down to certain joints. And that's kind of what I was drilled into me as a resident. These are, I forgot to mention at the beginning of this lecture that a lot of this is derived from John Rook, and I certainly have the back of my mind every time I'm dissecting, him whispering in my ear about what I'm doing right and what I'm doing wrong. So it's kind of drilled into you when it comes to the PI, and then obviously, minimizing periosteal stripping. One of the biggest differences, training in Georgia and then coming back up to New Jersey to practice was the tourniquet use. I was trained with epinephrine and doing dissection without tourniquets. When I came up to New Jersey, I was the only one that was doing that. Everyone else was using tourniquets. And I think part of it is, anatomic dissection, being able to, see certain structures and also be able to control bleeding and hemostasis. One thing I did adopt when it comes to, rear foot, surgery, specifically with tourniquet use, is dissecting wet, and then resecting with the tourniquet up, taking out your joint surfaces, because, those bones tend to bleed a little bit more. And then before leaving, the procedure, before closing, exiting, letting the tourniquet down and making sure you're controlling any of that bleeding before you suture up. With joint exposure, there's two different ways to kind of do that. There's disarticulation, which we would see in our hammer toe surgery or first MPJ, fusion procedures, trying to just disarticulate the joint to expose both joint surfaces, or joint distraction, and that's using either lamina spreaders or mini distractors or jig devices that can expand and contract the joint to allow for adequate exposure to the joint surfaces. Usually in more flattened or planal type of resections, that's what you would consider using joint distraction for. When it comes to reduction of the deformity, obviously you're looking at two different things when you're evaluating a patient preoperatively. You're looking at if the deformity or resection. So with planal resection, we're talking about taking away two flat, two surfaces in parallel to one another and allowing them to close. In contour resection, we're keeping the shape and keeping the actual attitude of both sides of the joint in the same position, and that allows more for, one, minimizing shortening, as well as being able to manipulate where we want this deformity to be corrected to. So obviously, we talked yesterday about first MPJ fusions, which we'll kind of go through here, and having the right position, in that contour resection kind of helps play into that role. With resection technique, we're trying to remove the articular cartilage, the subchondral bone plate, and expose cancellous bone substrate. You're looking for that classic paprika sign, bleeding through that spongy coral type bone and fenestrating to draw those bone cells out and allow them to be exposed in your arthrodesis site. One thing I like to do in surgery is use a fluted drill bit for this. Some people use smooth K-wires. I feel like using the fluted drill bit actually helps pull some of that deeper cancellous bone to the surface and allow for more good bone material to be fused. Instrumentation that we can use, obviously curettes, rongeurs, osteotome mallet, which is my personal favorite with a lot of things, rotary burr, saws, and now reamers, especially for fixed contour resection. One example of contour resection is first MPJ fusion, using reamers or curettes and rongeurs to maintain that shape of the head of the metatarsal and the base of the proximal phalanx, but allowing for good cancellous bleeding bone. We do have a preoperative way to sometimes measure the head of the metatarsal, and then you can also kind of correlate that to to reamers that you may use and be able to look at what size ahead of time, so you're kind of well prepared for any type of reaming resection. An example of planal resection, would be the lapidus procedure. Obviously, using flat surfaces to oppose one another. Osteotome and mallet here, using that as an example, and then obviously this is another example of planal resection with wedging, in the calcaneal cuboid joint, for a rigid deformity. We do also have now jigs. Jigs seem to be, the new hot thing for a lot of different procedures that we do, especially with the lapidus procedure, where you're doing a planal resection, technique, but the correction is built into the jig, and that's something that you always keep in mind when you're using these kind of cutting guides. That's going to be part of the correction, in the procedure. Temporary fixation, is always good. That way you can see where you're going to be able to put your hardware. You don't want to obviously put your temporary fixation where you're going to put your screw or where you're going to put your plate, because it'll just be in the way. But always good to be able to go back and change things if need be, if you're not happy with the way that the way that looks with your temporary fixation. Historically, with fixation, implants and devices, splintage, K-wire, Steinman pins, staples, even started doing, rigid compression with screws and plates as early as 1958. I think this is one of JR's first, this one, and then another, triple that we did back in residency with just 3 screws. Obviously now we're seeing some more newer school type of technology, one being, dynamic compression, plates and staples, implants using, bridge plating in conjunction with compression devices. Obviously more flexible materials or now radiolucent materials like PEEK, and then biointegrative technology. What I'm talking about with that is the difference between biointegrative technology and bioabsorbable technology is that there are new implants now that have the same type of fibers that you'd find in allogenic bone graft, and they are mixed with the same type of material that you'd see in bioabsorbable implants. And using these, they can kind of become osteoconductive bone void fillers. And what's nice about some of this is that the artifact that's left behind is just bone. With a lot of absorbable, materials that I've used in the past, I was kind of upset with the defect that would be left behind as the material did degrade or dissolve. With this new technology, now bone is integrated through the implant, and what's left behind is the patient's healthy bone. As far as fixation goes, this is kind of in relation to bone healing. Our biggest thing is that we want to achieve primary bone healing with early weight bearing as early as possible. And so whatever fixation you're picking, you want to make sure that it's robust enough, or it allows for the patient to get it as active as possible to facilitate bone healing. And that may be something as robust as compression plating or buttress plating, or it could be just with K-wires. When it comes to fixation, Glissane obviously said maintaining that fusion site in an undisturbed fashion until bone healing occurs, meaning that we want this bone to heal, and then once it's done that, it's better described as what Stephan Perrin described it as a race between bone healing and fixation failure. I kind of always tell patients that the implant or the plate, it stays in, but it's only really going to work for about 6 to 8 weeks, and at 6 to 8 weeks, the bone should be fused. In certain cases, it may take longer. In other cases, it may be a little bit shorter. But once it's healed, it's done its job. So we could take it out, and your foot would still be the same. We don't take it out unless it's causing a problem or irritating you. So that kind of idea, when you talk to patients, or you think about ahead of time, is that I just want this to be able to hold this in place for as long as I can get this bone to heal, and then after that, it's done its job, and it can stay in certainly, but it does not have to. So when it comes to regarding what you're going to choose, so whether it's a plate or a K-wire or screws, you want to look at the aspects of stability of those implants, and you want to look at making sure that you're not doing a lot to denude the area or strip the area, so that it's going to put a lot of pressure and strain on the on the joint itself. Certainly, one of the things that I always remember from when I first started doing, we'll talk about Lapidus in a little bit, was how much exposure was first done with a long incision from basically the cuneiform all the way down to the first MTPJ. And now seeing less and less, anatomic exposure and stripping of bones. And I think there's, some science to that it allows, hardware that can be used that will not allow, any trouble with the patient, or as far as denaturing the area or allowing for lack of good bleeding to the joint. Post-operative management must be protected against unsupported forces in weight bearing. So you want to promote early weight bearing and allow relative mobility. However, you want to make sure that weight bearing too early, you're not going to put too much strain on your arthrodesis site. There are other things that you can use to help enhance your arthrodesis site, whether it's bone graft, electrical bone stimulation, bone graft substitutes, aspirate. There's a lot of different biologics now that can be also used in conjunction with fixation. One thing I like to kind of, with all these that I point out, is that it's going to help facilitate bone healing. It's going to help facilitate your arthrodesis, being successful. It's not going to speed up the process. I think we all get the question of when is this going to be healed, or how long am I going to be out of work? When can I get back to sports? And using biologics or using certain fixation certainly can help protect these areas. But whether you're Michael Jordan or it doesn't really matter. The bone is going to heal in its certain time. So going back through just kind of comparing our AO and PI tenants, in summary with the Sain's principles, certainly, obviously removing all the cartilage and fibrous and dead sclerotic bone, also includes preserving the blood supply around the bone and keeping the periosteum intact. Obviously, we want good, accurate, close fitting of our fusion site, and that's achieved through anatomic reduction. And then certainly optimal position to appropriate of our fusion site for appropriate fixation to facilitate bone healing. And then maintaining it through and protecting it through its disruptive forces. So in summary, one thing that we talked about Gerard Yu and John Rook was also a big influence in my early career and residency. We talked about principles of learning, on top of principles of arthrodesis. Stephan Perrin was an AO founder and wrote a lot on bone healing, and he also was a kind of philosopher in the idea of learning as well. And he had this concept of readiness, exercise, and effect. Readiness was your motivation to learn, your motivation to prepare yourself to learn. And he called their lab, and we kind of called our lab at the PI the playground. It was our area where we could basically start what we called exercise, repetitively trying to learn new techniques and kind of test them and become good at them. And then the effect was that in the short term you achieved that goal, and in the long term you made behavioral changes for the greater good of your practice, and in our case, becoming better surgeons. So I just always kind of point out some philosophy on top of the science that we go through here. So thank you very much.